Okay, so I guess I'll just start us off. So hi everyone, welcome and thanks for joining us. I know I met a lot of you guys as I gave personal shout outs, but for those of you guys who don't know me, I'm one of the fourth years at University of Utah. My name's Grace and I'm the one who started this rad Discord. I'm gonna turn this over to April.
Yeah, my name's April. I'm also one of the fourth years. I'm, I think, an honorary moderator today just by proximity, but I get the distinct pleasure to introduce Dr. Wiggins. So Dr. Wiggins is one of our NeuroRad faculty. He specializes in head and neck radiology, and he also is high up in the administration for the University of Utah, so we are blessed to have him, and he's going to torture us, I think, for the next hour, so really lucky to have him teaching us today.
So I'm going to take over again and just kind of explain, as we're going to run this kind of similarly as our prior reviews. So this will be interactive, case-based. Dr. Wayne's going to show us a bunch of series of cases, which hopefully will be a pleasant experience and not the torture as April alluded to. Residents will be in the hot seat and take the case. Make sure to unmute your microphone. You guys are all muted when you join the session. So just unmute your microphone when you're taking the case. And then for those of you guys who have questions about the cases that we're talking about, feel free to use the chat. So anyway, I'm gonna not bore you guys with my talking. So Dr. Wiggins, take over.
Okay. I will take over and try to share. Okay, so we're going to continue what we did before, looking at a bunch of head and neck cases. So as Grace and April said, we're going to do kind of like hot seat. So you have to start off and you have to play the game. Even if you know what it is and you've seen the case, don't just shout out the diagnosis, but go through the process. This is an MRI. This is a T2. We're through the level of the blanket. I see a mass over here, because you have to give the tester the opportunity to kind of reset you if you're way off in left field, if you're actually talking about something else. Let's see. So you guys are going to choose who's going to look at what case and in what order?
Yes,
and just call out names. Is that right?
Yep. I have a list of people. So we're going to have Christian Kogel take the first case. He's a fourth year from University of Utah.
Hi. Okay. Christian, you ready?
I am ready.
Okay, sweet.
All right, what goes through here? So I'm looking at a coronal CT through the base of the skull,
right,
at the level of the sphenoid sinus, and
right. These are sphenoids, right?
Yeah, and it's a bone kernel, and I think this is the Vidian canal.
What's your second guess?
Then it's not a Vidian canal, so it's.
But what is that?
That's the Vidian canal.
That's the Vidian canal, good. Or pterygoid canal. Vidian, if you like to name stuff after dead people. So the pterygoid nerve or Vidian nerve goes through there. What is superior and lateral to the pterygoid or Vidian canal?
I have to guess. I think it's the spinous foramen, the oval.
Nope. This one is round in the coronal plane.
Rotundum. Foramen rotundum.
Yeah, we call it foramen. It's really a tube, but what goes through there?
It's V2.
V2, that's right. So the second division, the maxillary division of the trigeminal nerve goes through that. So that is the rotundum canal. A lot of people call it a foramen, but it's really a tube. But V2 is the nerve that goes through there. Right, good. See, Duke. They close that each time. Okay. Next case.
So I'm looking at axial MR through the posterior fossa. Upper left is a T1 pre. Next to it is a post.
Right.
And below is on the bottom right is a DWI, and on the left, like a T2, just a T2.
Yep.
So I do see a mass in the left CPA, that is low in signal intensity on T2 weighted images. It doesn't enhance. It shows restricted diffusion and is hyper intense on T2 weighted images. So I'm thinking about an epidermoid because of
epidermoid cyst. So we have something that's very bright. And I didn't show you an ADC, but you want it to be bright on diffusion and dark in ADC. You see it's bright on T2. It's like following CSF. So if you go cut this thing out, would you expect any problems?
No.
Is there a big deal to cut these off, or do you often cut these?
Yeah, they can rupture and cause a chemical meningitis, I think.
Well, that's usually a dermoid we're talking about, a ruptured dermoid when that happens. But the problem with epidermoid cysts is that they grow around things. So all these blood vessels and nerves are kind of going through them. So often if you cut them out, you have a problem post-operatively if you cut those guys out at that location.
Right.
Yeah, let me see if I try to get out of this and open it up again. I think the screen share may be cutting off the bottom. Is that better, sharing my whole screen?
Yeah, that looks good for me.
Okay, good. So the possible complication is that you, there are some complications you can get with cutting those out. Okay, next case.
I'm looking at a CT of the temporal bone. On the top is a corona, on the bottom is an axial.
Right.
It's bone window, bone kernel.
Right.
And there's a pacification of the middle ear cavity.
Right.
I don't see the ossicles very well. They seem very eroded, actually.
It almost looks like you can see the head of the malleus here, but you want to see a good ice cream cone, right?
Right, right.
What is the ice cream scoop? What is the ice cream cone scoop?
The malleus, and
right.
The rest
so
is
the head
incus.
of the malleus is the scoop, and the ice cream cone is the
incus.
Short process of the incus, right? Okay. So instead of the ice cream cone here, it looks like you have all this other stuff kind of around that area.
Right. So I'm thinking about additionally, there's also a pacification of the mastoid air cells. So I'm thinking about an infectious process that...
Yeah, long-term infection in the middle ear cavity sometimes has calcifications that are laid down on the ossicles. Sometimes you see thickening of the TM. What do you think of that long-term chronic infection of the middle ear cavity? Do you know what that is?
A confluent otomastoiditis?
Yeah, but if you have calcification, what do you call that?
Otosclerosis?
Well, that's changes of the bone around the middle ear. This is changes of the middle ear cavity. Otosclerosis or otospongiosis is change in this dense bone that's around the inner ear cavity. What do you call it when there's a long-term infection in the middle ear and you have calcification that are laid down in there?
Chronic mastoiditis, chronic otitis, tympanosclerosis.
Tympanosclerosis, there you go, tympanosclerosis. So long-term infection in the middle ear cavity, we have all these calcifications that are laid down, and you can see some along the TM. This is a tympanic annulus, the inferior attachment of the TM, and it goes up to the scutum or shield, and you see long-term infection along there. That's right, good. Okay, let's see, who's next? I think that's 3. Who's next, Grace or April?
Oh, sorry. I thought I hit unmute. Okay, next we have Almira and our full 4 from UIC.
Okay.
Hi. So we're looking at the coronal post-contrast T1 weighted non-fat, fat set.
Well, the fat's still bright, so maybe not fat set. Yeah.
It's weird.
The fat's still bright around there.
Right. Yeah. All right.
There's a lot of variability to that. If you look at cases from other sites, some people do a lot of fat set on everything post, some people don't do anything. So the fat is still bright. So let's say not fat set.
Yeah. So as a non-fat set post-contrast T1 weighted coronal, and what is striking is that we have all these enhancement along the dura. So we have dural enhancement diffusely, and I don't see anything else at this point. Is there any, does this patient have a shunt?
Good question. What if they had a procedure like a week ago, now they're having headaches and they're kind of woozy and dizzy, can't get up out of bed?
Sure, so then I would think that that procedure was an LP, and this is a, like intracranial hypotension that is causing—
Right, intracranial hypotension. So you have a lot of thickening around the outside. Some people would include metastatic disease. You want it to be more thick and nodular and asymmetric with Mets, but this is a great place for intracranial hypotension. And it's probably a lot more complicated than we talk about with patients with intracranial hypertension and hypotension cycling back and forth. The pressure's too high because we have a lot of good big Americans, and then you have a CSF leak, you know, a little cyst ruptures and the CSF leaks out. So then you become hypotension. Then that fibrosis off and you go back to hypertension over and over again. So this appearance is great for hypotension. That's right, good. Next case.
Okay, so we are looking at temporal bone. I think these are, either these are sagittal or—
yeah, they're an oblique, weird, sagittal kind of shoot the hoops view.
Postial, is that?
That's right, postial.
Yeah.
Short axis or postial if you love to name stuff after dead people. Yeah. That's right. So the postial projection, if you do these, is kind of a short axis.
Yeah, it's like parallel to the superior semicircular canal.
That's right.
Which is that one. And you're showing dehiscence of it on the right screen picture there.
That's right. So you've lost the bone over there. So how might that guy present clinically?
With vertigo and maybe—
vertigo, any kind of dizziness, weird things like that. We sometimes talk about a third window effect. What are the two windows that we normally see? Do you know what that guy is and what that guy is?
Sure. So the one inferior is so that one is the round window.
That's right. That's the round window.
Yeah, and the one above that is the vestibule.
So the vestibule is all of this structure.
Exactly.
Right.
So So the one above the oval round window is the oval window, the one that we—
So that's oval window and that's round window.
Yeah.
And the middle there is the vestibule.
Yeah.
And that's made up of two parts, the utricle and the saccule. And we think about them all responsible for our sensation of acceleration. So there's a little utricle and a saccule. The saccule is responsible for horizontal acceleration and the utricle is responsible for vertical acceleration. How we feel that. That's good. Okay, good. Next case.
All right, so we have a post-contrast axial through axial neck images through what I think two cuts of the larynx. One is the one on the right side is a supraglottic, and the one on the left side, because I think that's like at the on the left side of the screen, is at the glottis at the level of the true chord.
That's right. What is this guy right here?
A cricoid, and the two lateral ones are arytenoid, and that made me that helped me figure that this is at the level of the true chord.
That's exactly right. When you see the cricoid and the arytenoids on the same cut, you're at the level of the true vocal cords. That's right.
Okay, so on the left on screen, it does look like that the right true vocal cord is adducted, and there's no, and on the right side of the screen, so I see the arytenoid folds, they look symmetric. I don't oh, no, actually.
So the aryepiglottic folds are a little asymmetric. What are these air-filled spaces?
Yeah, those are the piriform sinuses.
That's right, that's piriform sinus.
Yeah, the left side is larger than the right side. And that goes along, so we have the sail sign on the left side, and we have the enlargement of the piriform sinus on that side. So the left vocal cord is paralyzed.
That's right. That's exactly right. So this is a left paralyzed cord. So you get the spinnaker sail sign, and that's the primary sign of a cord paralysis. The secondary signs are anteromedialization and thickening of the aryepiglottic fold, prominence of the piriform sinus, and we sometimes see what's called widening of the thyroidnoid gap. the space in between the thyroid cartilage and the arytenoid. So that's wider on this side than it is on this side. So those are the secondary signs of a cord paralysis. We also sometimes see asymmetry of the arytenoids. That's a secondary sign of a cord paralysis. That's right, good job. Let's see, is there one more or is the next person?
I think we might be moving on to the next person. Next we'll have Michael Weintraub on R4 from University of Utah.
Okay, Michael.
Hi, Dr. Wiggins.
Hey, how's it going?
Good. Okay. So we have on axial contrast enhanced non-fat suppressed MRI, two enhancing homogeneously enhancing lesions in the bilateral cerebellopontine angle cisterns, extending bilateral internal auditory canals, most consistent with CPA, bilateral CPA schwannomas. And so I think this person has NF2.
NF2, so you think these are neurofibromas?
No, I think these are schwannomas.
So what do you get with NF2?
It's MISME, so it's multiple schwannomas, ependymomas, and
multiple inherited
schwannomas, meningiomas,
and ependymomas.
Ependymomas, yeah.
That's right, great. Good job. So MISME syndrome, and there's another lesion there. It looks like in the cavernous sinus or middle ear. So we call it NF2, but it's really better for MISME syndrome, multiple inherited meningioma schwannomas. That's right. Good job. Okay, next case.
Dr. Wiggins.
Yeah.
We are still struggling to see the text at the bottom of your screen. If there's text,
I was trying to.
Can you just, if there's text, can you just tell us what it is?
Yeah, that's what I was saying. What is the syndrome?
Perfect. And then
trying to get the auto hide for my, it's very embarrassing. For some reason, it's not auto hiding my menu bar.
Yeah, that's okay. Just if there's any like question or something, just to make sure.
Yeah, I'll read it to you if we see it. Yes, ma'am. Okay, great. Next case.
Sorry, the window just disappeared. Oh, here we go. Okay, it's back. What is this structure? This is the superior orbital fissure.
That's right. What goes through there?
Cranial nerves. Cranial nerves 3, 4, D1, D2, and 6.
That's right. All the nerves go into the eyeball. So 3, 4, V1, and 6 all go through there. So on an axial CT, when you're at the level of the optic nerve canal, the optic nerve is special, he gets his own canal, there's always this cleft between the greater and lesser wing of the sphenoid. That's the supraorbital fissure. So all the nerves go into the eyeball, go through there, 3, 4, 6, and V1. That's right, good. Okay, next.
So I think that you still have one more case, right?
Yep. So this is a T2 space image through the, let's see, we're looking at the root entry zone of cranial nerve 5, I believe. There is the question about diagnosis.
What do you see?
I think
let's say it's a radiologic image and I want you to interpret the image.
Okay.
So it's a CSF bright sequence, KISS, space, Fiesta, T2 FSE, one of those silly things. So here's the big fibers of 5 on this side.
Yeah.
And what's this guy?
Meckel cave on the left.
Meckel's cave, or the trigeminal cistern. Meckel's cave, if you like to name stuff after dead people, right? So what do you think about the big fibers of 5 coming over here? Largest cranial nerve, big fibers coming out from the pons on both sides. Do you see any difference between one side and the other side?
Yeah, it's a little, the fibers look attenuated on the right-hand side.
Attenuated or smaller? Mm-hmm. Or smaller on that side. Anything else you see that might be interesting?
Is that, yeah, it looks normal on the left. It almost looks like the fibers are separated on the right, and they're smaller in caliber. I can't tell if it's a lesion that's involving the cisternal fiber.
You can tell me. I'm a doctor.
Yeah, so maybe.
So what is this guy?
I think that's one of the cisternal fibers of the right cranial nerve 5.
Well, that stuff is going over here, and it should be going here through the pores trigeminus, the opening of the trigeminal cistern or Meckel's cave. So let's say instead that the fibers of 5 are coming out here and they're going around this thing to get to the trigeminal cistern. If those are the fibers of 5, then what is this thing? And how do you think this guy's presenting? What is that?
That's the basilar artery.
Basilar artery. So what do you think this is? The basilar artery is a vessel.
Mm-hmm.
What do you think of this thing?
It's also a vessel.
It could also be a vessel. Mm-hmm. And it looks like 5 is going around that thing to get over to the trigeminal cistern. So if there's a blood vessel pushing on 5 right at the root entry zone or root exit zone, so 5 comes out to do V1 and V2 going forward to the cavernous sinus. V3 goes down through a valley. But if my chest is the pons and you have those big fibers of 5 coming out, if there's a blood vessel pushing right at the root entry zone, how might he present clinically?
Trigeminal neuralgia.
Trigeminal neuralgia. So he may have facial pain on that side. So this is a blood vessel that's pushing on 5 right at the root entry zone, and they often present with trigeminal neuralgia or trigeminal neuropathy. That's right. So he may have facial pain on that side. Good. Okay, next case. Say
Sorry,
next person.
Is this a particular vessel or like a known syndrome?
Yeah, you try to follow it to see which it is. Often it's the SCA or pica or AICA or a big vertebrobasilar dolichoectasia. But you have a blood vessel pushing on the root entry zone of 5, and that's what you often see with somebody with a trigeminal neuralgia.
Okay, thank you.
Okay.
Dr. Quickens, a quick question. Is there abnormal cystic structure in the right mesotemporal lobe? Yeah.
I think you may just be volume averaging through a sulcus over there. So I think that's just a sulcus. It's unrelated.
Okay, good. Thank you.
Okay, next person, Grace.
It's kind of a weird.
Right. Next up, we have Rahul from 4th year from Bridge.
Okay.
Trauma concerning for.
Yeah, vascular loop syndrome is what some people call that. That's right. And they present clinically with trigeminal neuralgia, a trigeminal neuralgia or a trigeminal neuropathy, any kind of pathology of the 5th nerve. Okay, next case.
Okay, so I see axial T1, axial T2, and a CT bone window image, and there's a large lytic lesion within the left temporal bone or sort of left skull base, which is bright on T1 and kind of heterogeneous on T2 with some dark components.
Well, is it mostly dark like muscle, or is it more bright, kind of like CSF?
On T2, it's more like CSF with some.
So it's kind of bright on T2. Okay, is it enhancing on the T1? Is this after contrast or before?
This looks like pre-contrast.
How do you know that?
Yeah, I think you're pointing out to the turbinates over there. The nasal turbinates are not enhancing, and I don't see any vascular.
Nose. So if the nose is dark, that's probably before contrast. That's right. Okay. So we have a lesion. Let's say it's the petrous apex, kind of the top of the petrous bone. It is expansile, and it's bright on T1 and T2. And it looks like it's pretty much just expanded and large. It's not like something that's making a matrix on the CT. So what do you think about that?
Probably if it's sort of petrous apex, T1 bright lesion without, I'd go for probably a cholesterol cyst.
Cholesterol granuloma, we sometimes see that, cholesterol cysts. Yeah, so it's bright on T1 and T2, and it's expansile on the CT. So if the CT looked normal, we might think maybe this is just fluid there, but it's expansile. This is enlarged. So bright on T1 and T2 is great for a cholesterol granuloma. Right. Good. Okay, next case.
So I have a sagittal CT images in the soft tissue and bone window. There's some prevertebral or retropharyngeal edema, and this fossa of calcification adjacent to the dens anteriorly. So I think this might be longus coli ossification with a reactive edema around it.
Great. So longus coli tendinitis or hydroxyapatite deposition. We have some calcifications laid down. So this is the anterior arch of C1, and this is the dens of 2. So under the anterior arch, there's this extra bone right there at that location. It's sometimes hard to pick out if you're not familiar with that anatomy. And as you mentioned, we have all this fluid going down, retropharyngeal fluid at that level. So a great case of longus coli tendinitis or hydroxyapatite deposition disease. Good. Great job. Okay, next case.
So this looks like a axial post-contrast T1, probably a small FOV image. And there's a large dural-based mass in the left CP angle cistern, which seems to extend into the left Meckel's cave or trigeminal cistern there.
That's right.
A dumbbell-shaped lesion there. I think differentials would be again a schwannoma from the left fifth nerve.
Schwannomas anywhere normally have a vector of spread along the course of the nerve, at least when they're small. When they're bigger, they get just huge bulbous masses. But usually schwannomas have that vector of spread along the expected course. Yeah, what do you think about this one in terms of its vector of spread?
It has a dural tail there, so maybe then a meningioma, but yeah. If it's a meningioma, I don't know whether the Meckel's cave lesion is a extension of it or if it's another.
Right. Do meningiomas usually escape the skull or try to go through holes in the skull base?
Not really. Probably not, I'd say.
They can actually. So if a meningioma with that dural tail as it goes along its dural base, if it goes over a foramen of the skull base, it may go down through the foramen. So you can actually have meningiomas that show up as a masticator space mass that may extend down along that area. So extraaxial dural base mass, it has dural tails. We think about a CSF vascular cleft between the lesion and the brain itself. And if they do go over a foramen, in this case, kind of the pars trigeminus, the opening of the trigeminal cave or Meckel's cave, it's extending into that area. That's right. So meningiomas can escape the skull if they go through any kind of foramen, like ovale or something else. That's right. Next case.
All right, so I think that marks our third case.
Next person.
We'll have Matthew Curtis, the 4th year from University of Utah.
Hey, Dr. Wiggins. I'm not nervous at all.
Really? And I'll ask you a lot of questions.
Oh, no. Okay. So the top image shows an axial T2.
So the question here is, what is the surgical treatment, if you can't quite read it?
Okay. The top image is an axial T2 showing a pretty large flow void off of the kind of the terminal right ICA. And then the image on the bottom left shows a coronal, looks like could be flare, or it could be T1. Hang on.
This one? Let's say it's T1 pre.
Yes, I think it's T1, and then we have a T1 post showing it light up. So we're dealing with a large saccular aneurysm off the terminal ICA. So I think we have two
The surgeons think it's a schwannoma, so they're going to the OR to resect it.
Yeah,
What do you think about that?
Soham
There's
just said
a
I should
pool,
biopsy
actually.
it.
Some of them think it's a meningioma, and some think it's a schwannoma. Which do you want to bet on?
Well, whenever someone asks me to biopsy something, I have to say no. That's the default answer on a board exam, is never biopsy something.
That's right.
This can either be done endovascularly with coils, but I think with one this big, you don't want to risk that. I think this would be like a frontal temporal craniotomy, where they would do.
So you can actually see the flow void of the supraclinoid ICA right in the middle of this thing. And sometimes you get this phase encoding chatter. You can ask Ulrich about that. But you get a little bit of artifact that goes kind of right to left in the phase encoding direction from that enhancing lesion. Very dark on the T2. So that's a great appearance for an aneurysm at that site. Good job. Exactly. Anytime somebody on boards or when they're showing you a case, as soon as they try to get you to biopsy something, you should hear alarm bells going off in your head. You go, okay, slow down. What else is going on here? What else could this be? So that's exactly right. This is actually an aneurysm. Good job. Next case.
All right. On the left, we have an axial, I think T1 post contrast of the orbits.
Right.
The
nose is bright, the nose.
The cavernous sinus is bright. And then we have the coronal through the orbits, T1 post contrast.
Right.
What I'm noticing, just comparing left to right.
Good job. Next case.
Diagnosis. I think we're probably going to get optic neuritis, but I'm trying to say why it's optic neuritis. The left, sorry.
We'll play the game. What do you see?
The right optic nerve is hypo. So the left is hyper enhancing rather than, but it doesn't seem very enlarged.
It is enhancing. Should it normally enhance?
No, it shouldn't. Well,
it normally does enhance. So it's hyper enhancing. It's enhancing at all, anything.
Right.
So then the next question is it the nerve itself that's enhancing, or is there enhancement kind of around the nerve?
On the coronal, it looks like it's around the nerve.
But is it like a halo kind of around the outside, like a meningioma with no enhancement in the middle, or is the middle enhancing?
I'd say the middle's enhancing as well.
The middle's enhancing. Good job. And you said that you thought this might be a neuritis?
Yeah, optic neuritis. Or
do you see that with the other cranial nerves?
No.
Why not?
Oh, because it's not optic in that case.
It's not optic?
Oh.
Is the optic nerve like the other nerves?
Yes and no. I'm not sure what you're trying to get at. It's extra axial.
Read my mind.
Yeah.
Is cranial nerve 2 like the other cranial nerves?
It's bigger. And no, it's not. It's not like the other cranial nerves.
Just say no.
No.
How is it different than the other nerves?
It has CSF around it.
It does have CSF around it. What else is different with cranial nerve 2? We get pathologies with the second cranial nerve that we don't ever talk about with the other guys. Why is that?
It's vascularized.
Well, all the cranial nerves have some vascularization to them. What's different about the second cranial nerve than all the others in terms of its CNS and PNS? Central.
Does it have a dural sheath?
It does got to have a dural sheath. What about central to peripheral myelinization? Have you ever heard that discussion? Do you know the transition zone between central and peripheral myelinization? A lot of people talk about with the cranial nerves, if you get a schwannoma or neuroma, a nerve sheath tumor, it's most likely to start at the transition zone between central and peripheral myelinization. Where is that transition zone with cranial nerve 2?
Don't know. I don't, it's not there.
It doesn't have one.
Okay.
The second cranial nerve is all central. There's no transition between central and peripheral myelinization. So we get a lot of pathology with the second cranial nerve that we never talk about with the other guys. Ischemia, optic nerve glioma, optic nerve meningioma, optic neuritis. We never talk about those things with the other, demyelinating kind of plaque within the nerve. Glioma. We never talk about that kind of pathology with the other cranial nerves because they all have a transition from a central to a peripheral myelinization. But theoretically, touching your eyeball is like touching your brain, right?
Okay.
Cranial nerve 2 never has a transition between central and peripheral myelinization.
So it's all central.
So this is a good, so you want to, this is a good case of neuritis. This guy had MS, maybe start having a discussion about Devix or something else like that. If you might want to do a diffusion to see if it's bright on diff and dark on ADC, because you can get ischemia of cranial nerve 2. We never talk about that with other cranial nerves. If this is really enlarged, we might talk about an optic nerve glioma. If there's calcification around the outside, we might talk about an optic nerve meningioma. So if there was enhancement around the nerve, but the nerve itself was not actually enhancing, then we might actually talk about a meningioma. Does that make sense?
Yes, it does.
So cranial nerve 2 is different than the others because it's all central. It's all myelin, like glial.
One thing
it never has the Schwann.
I couldn't tell which side was the abnormal side at first. Any advice?
That's right. Symmetry is hard for us, isn't it? That not everybody's perfectly symmetric like you. So when something's asymmetric, that's hard to tell sometimes. Is this the normal side or is the other side abnormal? The nerve should not normally enhance. It should look more like this. So when it's all enhancing, that can be confusing. Good point. Good. Okay, next case.
Okay, on the left, we have a CTA of the neck, looks like a MIP in the coronal plane. And we have the same on the right-hand side, but we're at a different level.
So 2 coronal post-contrasted CTs.
Mm-hmm. And I think what we're trying to see is in the left soft tissue neck, there are these circumscribed, large, heterogeneously enhancing lesions there.
Heterogeneous.
Is there a question to this?
Well, that's his diagnosis. But the question is like all the other ones, what's going on? What's the story?
Some of those look like calcifications in there.
There's weird calcifications. Do you see weird calcifications like that anywhere else?
Yeah, I see it in the left thyroid as well.
And the thyroid. So we have a mass in the thyroid with weird calcifications. And then we have a whole bunch of masses going up the neck also with similar calcifications.
Yeah, so
and they look like they're similar density. What do you think about?
I think it's metastatic thyroid cancer. And because of the calcifications, I think it's papillary.
Well, papillary is more common. It's supposed to be 95% papillary and follicular. We group them both in a differentiated thyroid carcinoma DTC. Often it's more mixed in our population. Everybody's patient population is sometimes different. But we sometimes, another thought is do you know of any other thyroid cancer that may have weird stellate or snowflake calcifications within them?
Medullary?
Medullary, that's exactly right. This was actually a medullary. They're more likely to have these weird calcifications. Anytime you see weird cystic masses in the neck, especially in a young woman, you think that may be cystic nodes. Think about differentiated thyroid carcinoma and look closely at the thyroid. And interestingly, the lesion in the thyroid is often very similar to the lesion that shows up in the nodes. So differentiated thyroid carcinoma is a great guess here. This was actually medullary. About 5% of thyroid cancer is supposed to be medullary. What if it was an older woman with a rapidly expansile thyroid mass that hurt, was painful? What kind of thyroid cancer is that?
Is that Reiter's or Riddell's?
Like Raynaud's? You can't CP or Climatry?
No.
Anaplastic thyroid carcinoma is an older woman with a rapidly expansile painful mass.
Okay.
But yeah, thyroid cancer is almost always differentiated thyroid carcinoma. And it's supposed to be 95% papillary and 5% follicular, but often they're mixed. Depending on your patient population, you may see more or less. And like prostate cancer, it's probably one of those things where a lot of people die with thyroid or prostate cancer. It never bothers you. You wouldn't have known it was there if you didn't go look for it. So we think about these incidental lesions.
As far as the test is concerned, should we consider calcification of the mnemonic for medullary?
No, but you often see it. Medullary often has these snowflake stellate calcifications within it. So if we see that appearance, we often think about medullary, but other things can do it, especially treated nodes. Lymphoproliferative disorders, lymphoma, leukemia, CLL, ALL, after you treat them, they may have eggshell calcifications in the nodes. TB, weird cat scratch. There are a lot of other things that can cause weird calcifications in lymph nodes.
And as far as Castleman syndrome, should that be on my differential?
Probably not. If you said a lymphoproliferative disorder, lymphoma, leukemia, CLL, ALL, Castleman's, all those different variations of that would be pretty rare for Castleman's. We would want to think about a differentiated thyroid carcinoma first. It's a direct extension of brain. Oh, right. So cranial nerve 2 is a direct extension of brain. So you think about touching your eyeball is like touching your brain. That's why cranial nerve 2 is different. Good. Okay, next case.
All right, next up we have Amin from UCSD, who's a 4th year.
Okay, Amin.
Okay, hello. So
Hey.
we have a axial post-contrast CT,
Yep.
and then we have a axial post-contrast fat-sat MRI. So there is a heterogeneous enhancing mass centered along the anterior wall of the left maxillary sinus and within maxillary sinus, actually, yeah. And it is enhancing, looks like there is no bony erosion.
Well, you've lost some of the walls of the maxillary sinus, so there might have been erosion there, but yeah.
Okay, yeah. So there is actually.
But that's a big thing in the head and neck world. We talk about the lesion and we talk about the stuff around the lesion. How is the stuff around it reacting to it? Is anybody angry about this thing, or is it just sitting there and nobody seems to care? So in this case, we have a mass. So it looks like a big mass that's destroying bone. It's chewing it up. So your most likely differential pathology is what?
Most likely is cancer.
Cancer? And what kind of cancer? What's the most common cancer head and neck?
Squamous cell carcinoma.
Squame, okay. When we talk about squames, we often talk about skin squames and we talk about the upper digestive tract. So with skin squames, what do they like to do in terms of spread?
In terms of spreading?
Spreading. How do they spread?
To the lymph nodes.
They go to lymph nodes. We talk about lymph nodes more commonly with upper air digestive tract. What do we talk about with skin squames? How do they spread in different areas?
Oh, along the nerves.
Along the nerves. What do we call that?
Perineural spread.
Perineural tumor spread, right. Sometimes we differentiate perineural invasion as a pathology thing and perineural tumor spread as an imaging thing. But if you had a tumor at this location, what might you think about in terms of spread with perineural tumor spread? What is the route? What nerves would this get on?
You mean for this lesion or in general?
For this lesion, yeah, this one.
For this one, what nerve? So I'm thinking V2.
V2, that's right. So where does V2 go? There's a lot of places to look this up, and this is hard. Perineural tumor spread is kind of the head and neck imager shtick.
It goes to foramen rotundum.
Rotundum, where does it go before that?
Turbopalatin Fossa.
Turbopalatin Fossa, where does it go before that?
Infraorbital foramen.
Yeah, below the eyeball. So it's going under the eyeball back towards the Turbopalatin Fossa, and then it goes through rotundum. Okay, now that we know that anatomy, what do you think about the imaging here?
Okay, so here, so we're looking at the Turbopalatin foramen, look for perineural spread along the V2 and in the infraorbital foramen.
So it goes under the eyeball. So what do you think about this part right here?
Yeah, so it's expanded. It's actually eroded, yeah. Enhancing.
And it's enhancing, huh?
Enhancing, yeah.
So what do you think that is?
So that's perineural spread along the
perineural tumor spread. So after it goes under the eyeball, where does it go then?
Turbopalatin Fossa.
Okay. What do you think about the Turbopalatin Fossa?
It's also enhancing and expanded.
What do you think about the density compared to the other side?
And losing fat.
We've lost the fat there. Very good. So when you're doing a CT, you want a window at something like 440 so that air is different than fat. Because where there's air and where there's fat is very important for us in all of these pathologies. And that's why the T1 before contrast is very important on MRI. Because if you know where there's supposed to be air and where there's supposed to be fat, that's very helpful. Okay, so after the Turbopalatin Fossa, then where does it go?
To the foramen rotundum.
Rotundum, it's really a tube, so it's really a canal, but people always call it rotundum foramen, that's right. So what do you think about that here on the MR?
Yeah, that's also enhancing.
That's enhancing. It's enhancing a lot more than the other side. So where does it go? What's behind that? Where does it go after that?
after V2 goes to the cistern, to the trigeminal cistern.
What's before that?
Meckel's cave.
Yeah, what's before that? So if you think about like where the pituitary is kind of in the midline, on both sides of that, you have what?
Oh, a cavernous sinus.
The cavernous sinus, these valveless venous sinusoids, right? The cavernous sinuses. And you have all these cranial nerves there, right? You've got 3. He's superolateral. You have 4 just under him. And then V1 and V2 are going down the walls. And we think about 6 kind of being loose in those valveless sinusoids. And they actually connect under the pituitary gland. So one cavernous sinus connects with the other guy under the pituitary gland. There's a dural venous sinus that goes under that at that location. So this is perineal tumors right now. The surgeons can see this, but they can't see this, and they can't see this, and they can't see this, and they can't see this stuff, or if it goes back even further. If this goes all the way back and touches the brain, he's probably not a very good surgical candidate anymore. You're not going to change this guy's M&M by doing a big face surgery if it's already touching the pons. So perineal tumor spread is our job to kind of talk about it and see where it goes. Good. Okay, next case.
Okay, so a axial and coronal CT non-contrast with bone kernel.
Right.
So I'm trying to find.
What do you think about symmetry in this area?
Some fullness on the left side. And
so what's this guy?
This one is inferior turbinate.
Right. What's this guy?
Middle.
Good. So what's that guy?
Superior.
Superior. Okay. So what do you think about them over here on this side?
So on this side, I can see them. So maybe they're eroded or in a different state.
Well, what do you think about this opening here, the nasal choana, the opening on this side compared to on this side?
So it's narrowed on the left side.
It's narrowed. So if you had if this was a pediatric case that kind of had nasal obstruction on one side?
Yeah. You mean syndrome?
Could be a syndrome, but this is just one thing that we're talking about.
Yeah.
What if one side of the nose never opened up?
Yeah, choanal atresia.
Choanal atresia, or piriform aperture atresia, something like that. One side never opened up. So if you do a lot of pediatric cases, you may see things like this obstruction. Maybe they tried to pass the nasogastric tube on that side and they couldn't get in through the pass. So we do the CT and we look for that narrowing. So we might talk about a choanal atresia or piriform aperture atresia, something like that in that case. Good. Okay, next case.
Mm-hmm. Okay, so by 2 fat-sat axial post-contrast MRIs.
Yep.
So on the left-sided image, it looks like there is a enhancing lesion that's centered in the petrous apex and has some mass effect on the cerebellum, and CP angle is basically extruding through the CP angle. And then there is also some abnormal enhancement in the right masticator space.
It might be the carotid sheath or space. The masticator space is going to be around the muscles of mastication, around the mandible. So you have your masseter out lateral and your medial and lateral pterygoid medially. So this thing might technically be behind the masticator space. But what is this guy right here? If this lesion is centered right there.
This one.
Do you know what that is?
Yeah, that's carotid canal.
Well, the carotid.
Ovale.
Well, no, ovale is going to be up here. If you find your condylar head in the medial part, and you go a centimeter medial and a centimeter anterior, that's where ovale is. But what is this vein coming down that's around here? The vein comes around here and then it goes in here.
Oh, that's for jugular foramen?
Jugular foramen, great. So we've got a lesion centered in the jugular foramen, okay?
Yeah, and then has some flow voids and some...
Has a lot of flow voids, that's exactly right. We have a lesion centered at the jugular foramen that has a lot of flow voids.
Okay, so it's probably a glomus jugulare.
Best for a paraganglioma or a glomus jugulare, that's right. So paragangliomas we talk about as salt and pepper, they have a lot of flow voids. So if you have a lesion centered at the jugular foramen, it can be a schwannoma, meningioma, or paraganglioma most commonly. The meningiomas have enhancement in all directions, like we mentioned, they may escape throughout foramen. The schwannomas, when they get big enough, have intratumoral cysts, and paragangliomas have these flow voids, salt and pepper. That's right. So this is a good example of a jugular foramen paraganglioma. Great. Okay, next.
Okay, so here we have a axial and coronal post-contrast MRI.
Right.
And then FATSAT. So there is a enhancement and enlargement and thickening of the right lateral rectus muscle.
Yep.
And looks like the other muscles are okay, and there is some abnormal enhancement in the intraconal space.
Right, there's the tissues around this thing are angry about it, right?
Yeah.
So you have inflammatory, infectious type changes or something around there, right?
Yeah.
So if your eyeball is trying to escape the skull, we have two big questions that we all often start with clinically. Do you know what those are?
Exophthalmos.
Yeah, like proptosis. If your eyeball is sticking out, what are the two big clinical questions you want to ask? You want to know, did the proptosis happen quickly or slowly? And does it hurt?
Yeah.
So what if I told you that this happened relatively quickly and it hurts a lot?
Then I'm thinking more infectious inflammatory, like pseudotumor.
Pseudotumor, IOID, idiopathic orbital inflammatory disease, or pseudotumor, that hurts. That's right. So this is a good example of that. Now there is a differential here. So you can't have metastatic disease to the eyeball, and there's IgG forward and other weird things that may happen. But if this hurts and you have proptosis in that sense that hurts, we think about pseudotumor because pseudotumor hurts. That's right. Good job. Okay, next.
All right, next up we have April Griffith. She'll be taking the next case.
Okay, Dr. Griffith.
Hi, Dr. Wiggins. How are you?
Hi, Dr. Griffith. I'm fine. How are you?
Oh, just doing so well. So we have two axial images through the maxillary sinus. On the left, looks like a, I think, CT. On the right, we have probably a post-con T1.
Let's say it's a T2.
Oh, a T2 then, FATSAT T2. So we have a T2 bright material that's filling the right maxillary sinus, and it also looks like it extends back into kind of the nasopharynx as well. So this could, there doesn't seem to be any bony erosion on either image or significant bony remodeling. So this could just represent
what are the soft tissues around this guy?
Yeah,
we often talk about lesions in the head and neck, and we talk about the stuff around it. Is anybody angry about this thing?
No.
No, nobody seems to care.
Yeah, everything looks really nice. So this could be just like a run-of-the-mill sinus disease, maybe an obstructive pattern.
Do you often see run-of-the-mill sinus disease with a giant mass that looks like it goes all the way back into the nasopharynx?
No.
When you look in this guy's mouth, there's two things hanging down in the back.
Yeah, run-of-the-mill sinus disease. The other thing would be maybe so something that's pretty cellular, like a lymphoma potentially.
Well, T2 is a rough marker of tumor cellularity. Lymphomas are often what on T2?
I guess generally they're dark on T2.
Dark. Lymphoma is usually dark on T2. T2, like ADC, is a rough marker of tumor cellularity. So things that are hypercellular are more likely to be dark on T2. Things that are hypocellular are often bright on T2.
So not a lymphoma or anything that's really hypercellular. So what about a polyp, like an inverted polyp?
Inverted polyp. So an inverted polyp is kind of like a wart on the nose. We talk about the cerebriform enhancement we see around it. Often there's a sclerotic margin from where it attaches, and they have a 10 to 15% malignant degeneration into a squamous cell carcinoma or something else exciting. But that's a soft tissue mass. It's like a wart in the nose. And when we give contrast, it's cerebriform enhancement. What do you think about the density and the signal intensity of this thing?
Well, it is light bulb bright on T2. So like it would be potentially fluid or myxoid.
Yeah. Is this density good for fluid?
Yes, it is.
Awesome for fluid.
Yeah.
What if this was just a little cyst in the maxillary sinus? It wasn't going out in the nasal vault. Then what would you call it?
Just a mucus retention cyst.
Mucus retention cyst, bam. What if you have a mucus retention cyst that escapes the maxillary sinus? It goes into the nasal vault and then it may extend back into the nasopharynx. What do we call that?
A really big mucus retention cyst.
A really big retention cyst. Sometimes we give it a different name.
Is this a coatrial polyp?
Antrochoanal polyp, choana opening, antral, the maxillary antrum, antrochoanal polyp. It's a big mucus retention. So it's totally fluid. It's all fluid density or intensity on NMR, smooth, imperceptible border or wall. It's like a mucus retention cyst that got really big and escaped the maxillary sinus. That's what we think about with an antrochoanal polyp. That's right, good. Okay, next case.
Okay, what percentage of head and neck cancer is squamous cell? I would say either 75 or 90%.
What's the higher one?
90%.
Yeah, it's almost all squame, right? Head and neck cancer is almost all squame. We talk about the skin and the upper digestive tract, but by far and away, squame is the most common head and neck cancer. If you think about perineal tumor spread, adenoid cystic, a minor salivary gland carcinoma type tumor, really likes to have perineal tumor spread. But what do we see most perineural tumor spread with in terms of a big pathology group?
Squame.
Squame, because we see so many more squames than we do anything else, right? Okay, so 90% of all head and neck cancer is squame, either skin or upper digestive tract. Good. Okay, next case.
Okay.
Normal or abnormal?
Abnormal. This is a VA case, I think.
Could be. What if it looks like parts are really small compared to the other parts? Like let's say we looked up big and it looked like the eyeballs in the inner ear were really big.
Yeah.
Compared to everything else.
A VA case where children were veterans in the Army.
Yeah, after the children had served in the military and they came home for Afghanistan, they were then treated at the VA.
Yes, exactly. Okay, so pediatric case. We see this multiloculated, so these are two contrast enhanced axial images through the neck, through the soft tissue neck. We see this enlarged soft tissue mass that has multiple compartments, enhances with heterogeneous enhancement. It looks like it's transspatial. So I'm wondering if this is like a lymphatic malformation.
A lymphatic, so venal lymphatic malformation. And what if you have a venal lymphatic malformation that's like all lymphatic elements? What do we call that?
Just a lymphatic malformation?
A cystic hygroma is what we sometimes call it. So a venal lymphatic malformation, if it has a lot of vascular elements, we sometimes call it a hemangioma. If it's all venous elements, if it's all lymphatic elements, we sometimes call it a cystic hygroma. So those are both on that spectrum of venal lymphatic malformations. And if you're at it, especially if you do a lot of pediatric stuff, you may have long discussions about the IVISA classification, IVA, SSA, with rich and niche and rapidly involuting and non-involuting cavernous hemangiomas and these different types of vascular elements that may be within a lesion.
So Out of curiosity, so the only reason I made the joke was that about the VA is that it's like obviously a big lesion, so it would present potentially late in an adult.
At the VA.
At the VA, yes. But it's a child, obviously. So are there telltale signs on these images that it's a pediatric patient?
Well, what do you think about the size of the vertebral bodies compared to everything else?
I guess they're really relatively big.
It looks like they're huge.
Okay.
It looks like the vertebral body is like half the neck, front to back.
Okay.
And if you go up higher, this kid's eyeballs are like this big.
Okay.
Strangely, the eyeballs and even the inner ear, you know, if you look at the temporal bone and you think about the ice cream cone and the ossicles, they look huge in a kid because when you're born, the temporal bone and the ossicles are normal adult sized and the rest of the body actually grows up kind of around them.
Okay. Okay, that's useful.
But yeah, usually they'll tell you. And again, when you're doing a hot seat like this, that's why you want to do all this thinking out loud. So the examiner has the chance to redirect you if you go off in the wrong direction. So a transfacial multiseptated mass that looks like it has a lot of fluid, that's a great appearance for a venal lymphatic malformation. If it's all lymphatic elements, we often call that a cystic hygroma.
Okay, thank you.
Next case, thank you.
Next, I will be taking the next case. All right, so we have multiple axial sequences. The top left is a diffusion weighted sequence. The top right would be a T2 weighted. The bottom right left. I have trouble with lefts and rights sometimes. And also the fact that my video camera doesn't work anymore is very distracting. Anyway, so the bottom left is gonna be your T1 pre, and your bottom right is gonna be your T1 post. Okay, so there is a lesion centered in the left CP angle that is diffusing restricting, and then it's also T2 intermediate, somewhat bright, T1.
I didn't show you the ADC, but let's say, yeah, it's dark in the ADC. Just because it's bright on the diffusion is not diffusion restriction. Just because it's dark on the ADC is not restrictive diffusion. It has to be bright on the diffusion and dark on the ADC. But yeah, let's say this was dark on the ADC, so it really is restricted or reduced if you're at UCSF.
Okay, and then on the T1 pre and post, we do not see very much enhancement with this lesion. So I think my top thing and my differential would be like a cholesteatoma or like an epidermoid cyst, something along those lines. Right. In the diffusion restriction.
Same thing on pathology. The H&E stain of a cholesteatoma is the same as an epidermoid cyst. Now, where this gets tricky is a lot of people like to have the discussion about, well, what if this patient showed up with deep face pain behind the eyeball, his sixth nerve is out, and he's got otorrhea, infected fluid coming out his ear?
I guess you have to consider, could this be like an abscess or an infection kind of process?
And what do you call that if you like to name stuff after dead people, or just an infection of the petrous apex?
Is it granigo?
Gratinegros or apical petrositis, if you don't like to name stuff after dead people. So you have that triad of deep face pain behind the eyeball, that's 5. Your sixth nerve is out, and otorrhea, that's apical petrositis. That's supposed to be the triad with infection of the petrous apex. And some people will say, well, with a petrous apicitis, it may have a well-formed abscess. That could technically be bright on diffusion and dark in ADC. I think that's extremely rare. If somebody shows you something that's bright on diff and dark in ADC, they're almost always talking about a cholesteatoma if it's around the temporal bone. So that, I think, is what you should probably say first. And if they kind of keep harassing you to keep going, then you might have that discussion about apical petrositis.
Okay, got it.
But this is a cholesteatoma. Good job. Next.
Dr. Wiggins, before we move on,
yeah.
Can you clarify how to distinguish between a cholesteatoma and an epidermoid?
Same thing. H&E stain is exactly the same, an epidermoid cyst or a cholesteatoma. If you take this stuff and you give it to a pathologist and you say, I got this out of the CP angle, he says epidermoid cyst. If you give him the exact same stuff and you say, I cut this out of the middle ear cavity, he says cholesteatoma.
Okay.
So cholesteatoma and epidermoid cyst, they're both just skin in the wrong place.
Okay. Okay, that's useful. Thank you.
Okay. Next case.
Okay, so this case looks like we have like an angio image DSA of the carotids. And then looks like on the other image on the other side, I'm guessing it's the contralateral carotid artery. And in the center image, we have an axial contrast enhanced CT. And the first thing I notice is that on the left carotid, there is splaying of the internal and external carotid arteries. And we can see that on the DSA. And there's a very prominent tumoral blush, as in this is a very highly vascular lesion. So the thing that really comes to mind is this glomus carotid body tumor, like a paraganglioma at the carotid body.
But this is bilateral.
I mean, well, yeah.
These ever bilateral?
They have bilateral sometimes.
Yeah, how often are they bilateral?
I think it's rarer. I'm not sure the percent.
Somewhere around 10 to 15, 20% or something. Okay. If you're in a place where there's a lot of weird genetic abnormalities, you might see more of these. There's some family history. So there's a genetic predisposition. But bilateral carotid body tumors. So you shouldn't see any of this blush in between the ICA and the ECA. So all of that, as you mentioned, angiographic angiophase blush is abnormal. How big should the carotid body actually be? How big is a normal carotid body?
I'd say it's, well, I'm not sure the actual size cutoff, but I would say that it shouldn't be causing mass effect on the bifurcation. Like you shouldn't see spreading and widening.
It might cause some, but 6 millimeters is a good cutoff. If it's smaller than 6 millimeters, if you see a mass in between the ICA and the ECA and it's 6 millimeters or less, it's probably just a normal carotid body at that location. Sometimes when we talk about pathology, we have important checkpoints, or there's something we want to be sure we mention. Is there anything with a carotid body paraganglioma that you mention in your report so that the surgeons have a better idea of how they might want to treat that patient?
I'm not sure. I mean, does it have something to do with like the deep lobe of the parotid gland?
Well, no, this is at the carotid bifurcation.
Yeah, sorry.
We try to mention how far around the ICA the lesion extends. Okay. If it goes all the way around the ICA, it's harder for them to cut out without the guy having a bad outcome. So if you ever have a carotid body tumor, try to mention how far around the ICA it looks like the lesion goes. And if you see one, go and look at the other side to see if it's bilateral. So that's a key point. So bilateral carotid body tumors, 10 to 15% bilateral. Good. Next case.
Okay, so in this case, we have an axial bone window construction CT. It looks like we're centered on the left external auditory canal. And then on the right image, we have a let's see, looks like a T1 post lead image. Right. And its axial is centered in the same window. And first thing I'm noticing is in that external auditory canal, external to the tympanic membrane, there is a kind of soft tissue, kind of rounded density. Right. And we can see that on the same sequence that it's a hyperintense, which means it's probably enhancing lesion in the external auditory canal. So I'm wondering, I'm not too sure. I think posteriorly in the mastoid air cells, there's also a pacification of those anterior mastoid air cells, and also on that T1 post, there's that enhancement. So I'm wondering, could it be like a mastoiditis that potentially? Well,
what do you think of the rest of the mastoid air cells?
It looks very clean, so I'm not really liking it.
Yeah, the rest don't look angry, do they?
No.
So maybe not an infectious inflammatory kind of thing, because the surrounding soft tissues don't look very angry about this thing. But it might be more likely for something to start here in the mastoids and then go into the EAC than it is for something to start in the EAC and go into those air cells. Okay. So the next question is, what is normally going through those mastoid air cells that you might have a tumor of that extends out?
So is this a facial nerve schwannoma arising from the mastoid segment of the?
That's exactly right. Good job. So you have the facial nerve that goes through the cistern, so cisternal segment, through the IAC. There's a little labyrinthine segment, then a tympanic segment going back, and then a descending or mastoid segment that comes out here. And then it comes out that hole in the head in between the styloid and the mastoid process called the What's the hole in between the styloid and the mastoid process?
The stylomastoid foramen.
Stylomastoid foramen, that's right. And then it splits in the pes anserina. So it has all those branches as it spreads out through the face, right? So there's another pes anserinus on the knee, but that one's not important. Only the one in the head and neck is important. So this is a descending mastoid segment facial nerve, schwannoma. That's exactly right. A mucocele, if it was just fluid, we might think it's just fluid with not solidly enhancing kind of thing. And a mucocele, we think about expansile changes, but this thing really looks kind of like it's destroying the bone around there. But that might be something else to consider. Usually a mucocele, that's kind of a generic phrase. A retention cyst in the submandibular gland, we actually call a mucocele. But if we have a retention cyst in the sublingual gland, we interestingly call that a sialocele. So is it a mucocele, maybe a generic term for a cyst full of mucus that might be thicker, waterier stuff than a sialocele? That's a retention cyst full of saliva. So that might be thinner fluid in it. But a mucocele, we would expect to not enhance homogeneously. It might just enhance around the outside. Good. Okay, next.
All right, next up we have Nandan. He's a fourth-year resident from University of Mexico.
Hi, good afternoon.
Albuquerque.
Yeah. Okay, so it looks like we have a axial bone window CT on the left of the screen, and a T2 weighted axial MR on the right. And looks like there is asymmetric expansion of the left vestibular canal. Or I'm not sure if that might.
Oh, that part? I think that's just a high riding jug. I'll give you that.
Okay, okay.
Now, remember, not all of these are kind of Aunt Minnie. Sometimes it's just a discussion about what it could be.
Okay.
So what do you think about this stuff here? And this here?
Okay. Okay, so it almost looks like it has a ground glass-like appearance. It's centered
kind of ground glass, but if you say ground glass, everybody's going to start thinking fibrous dysplasia, and that's an intrinsic osseous expansile thing. And I can see the bone. The bone itself is not really expanded. There's something extra on both sides of the bone.
Okay.
So what's on both sides of the bone right there at that level?
Could it be periosteo?
It could be, but you remember we were just talking about.
Oh, it's like the cavernous sinus.
Cavernous sinuses. The cavernous sinuses are on both sides of the bone right there. Okay, so we got cavernous sinus. Are these normal cavernous sinuses?
No, they're not.
And why are they not normal?
They are expanded.
They're too thick, right? That's big.
Right.
The cavernous sinuses are big on both sides on the CT. And what do you think about this sinus air cell compared to this?
Looks like compared to the posterior ethmoid, the sphenoid is just completely effaced. And there's osteoneogenesis.
Completely opacified. Right, osteoneogenesis or neo-osteogenesis, if speech recognition takes that better. We used to call it mucoperiosteal reaction, but it turns out the mucosal surface is technically normal. So we call it neo-osteogenesis or osteoneogenesis. So infectious looking stuff is going on the sphenoid, and both cavernous sinuses are too big. Okay, so the MR, this is a T2, CSF is bright. What do you think about the cavernous sinuses there on both sides on the T2?
Looks like they have a heterogeneous signal, and there's probably some infectious debris, within them.
And is it bright or dark?
It's dark.
Dark. It's a dark on the T2. So we have some infectious, inflammatory looking stuff on the CT. It's very dark on the T2, and it looks like it's in both the cavernous sinuses and kind of the central skull base. So infectious, inflammatory stuff going on both cavernous sinuses. So we have a differential here. If he had had trauma, maybe we might think about an AV fistula, and we talk about direct and indirect, and we know that if we inject one side, it goes to the other. If this was infection, like this hurt, we talked about IOID a little while ago, pseudotumor, idiopathic orbital inflammatory disease. What if this never enhanced when we gave contrast? What if both the cavernous sinuses were not enhancing?
I guess you could think about thrombosis, like
thrombosis, cavernous sinus thrombosis, bad sphenoid sinus disease, and the sphenoid disease extended laterally on both sides into the cavernous sinuses and led to cavernous sinus thrombosis. That's right. We want to be sure this isn't an osseous thing. Is this an intrinsic osseous lesion like a tumor? If you have a marrow replacing process, that's a big differential. Mets, myeloma, lymphoma, leukemia, plasmacytoma, e.g. sarcoid. It could be a whole bunch of different things. But very dark on T2 here. And if it's not enhancing, or if it's weird enhancing and enlarged bilateral cavernous sinuses, that's a case we might think about bilateral cavernous sinus thrombosis. If this hurt really a whole lot, we might think about a low-grade idiopathic inflammatory process like Toulouse-Hunt. Usually that's just on one side. We think about that like IOID in the eyeball. It's just extended back into the cavernous sinus. Toulouse-Hunt or IOID, pseudotumor, that might be a low-grade idiopathic inflammatory process of the cavernous sinus. But that would probably be our differential on a case like this. Good job. Okay, next case. Short-term memory.
Okay, so it looks like we have a contrast enhanced and T2 weighted axial MR sequences of the neck. And it looks like there is a transspatial multiseptated mass that's T2 hyperintense and does not enhance, although the peripheral septations do enhance. So once again, you'd be thinking of a venous lymphatic malformation.
But this is enhancing. Does that enhance?
No, then I guess then you'll be thinking about like a venous malformation.
With enhancing septations?
No.
What if I'm trying to trick you?
I guess it can.
Yeah, so the septations within a venous lymphatic malformation may enhance. So these things may be sitting there, but it may suddenly get bigger if they become infected. So you can see enhancement of the septations around that. So still a good appearance for a venous lymphatic malformation, a transspatial multiseptated fluid density mass. They can get infected, therefore they can enhance. That's right. Okay, good job. Next.
Okay, so we have T2 weighted axial MR on the left and post-contrast axial MR on the right. Centered at the level of the orbits. And there's expansion of the prechiasmatic optic nerve. It's
hard to tell sometimes just on one cut, but yeah, let's say this is the optic nerve that's big, right?
Okay, and it looks like there's enhancement of the sheath around it.
So the nerve and the sheath are both enhancing and expanded?
Right. So I guess, differential considerations may include meningioma or optic nerve glioma.
Yeah, great appearance for optic nerve glioma. The whole tumor is big. You can actually see the rectus muscles kind of going around it, and the soft tissues right next to it don't look very angry about this thing. So what do you think about an optic nerve glioma happening in the second cranial nerve? Do you see gliomas in the other cranial nerves?
No, you don't.
Why not?
Because this is like an extension of the CNS.
It's like CNS stuff, right? So yeah. Cranial nerve 2, we get all these other pathologies within it. Good. Okay, next case.
Okay, so we have a coronal bone window, CT, at the level of the sphenoid sinuses. And is that the foraminal valley?
Are you asking me? I'm the one asking the questions here.
I'm going to guess foraminal valley.
That is foraminal valley. That's right. Okay. What goes through there?
That would be V3.
V3, that's right. Yeah. What is that guy?
Is that the eustachian tube?
Well, no, the eustachian tube is this opening behind it. But what is the bump in front of the eustachian tube?
The torus palatinus.
The torus tubarius, that bump in front of it, that's right. And the lateral pharyngeal recess we think about is behind that. The bottom of the lateral pharyngeal recess is where nasopharyngeal carcinomas. So when we see that torus tubarius, that bump, we know we're at the level of the nasopharynx at that level, that's right. So that is ovale. So again, anytime you want to find ovale, it's a little bit harder on MR. Find your condylar heads and go a centimeter medial and a centimeter anterior and that's where you're going to see ovale. And that's the high-heeled footprint of the skull base. So the oval part is ovale. That's where V3 is going through. And the spine of the shoe is?
Spinosa.
Spinosa. And what goes through there?
The middle meningeal artery.
Middle meningeal artery, right. Very good. So that's how you find ovale. Find the condylar head, find the medial part, go a centimeter medial, and then a centimeter anterior, and that's ovale. Good. Okay, next.
Dr. Wiggin.
Next up, we're gonna have Jyotsna. She's a R3 from Mount Sinai, Miami, and I think April was trying to say something.
Yes. Before you move on, there was a question in the chat about the optic nerve glioma case. Question of why the nerve is not enhancing.
Yeah, sometimes it might be because so instead of the Schwann cells around the outside of the nerve, it's all glial. So those glial cells is where the nerve may arise. So you may sometimes find the optic nerve going through the optic nerve glioma, and it looks kind of like it's the outside that's all enlarged. So that's where that happens. And just like a glial-based tumor in your brain, it may be a little heterogeneous sometimes. If you think about those stupid World Health Organization, the WHO1, the WHO2, the WHO3, the WHO4, what kind of malignant degeneration your tumor is going through. So again, we talk about that central to peripheral myelinization changes, the Oslo-Weber zone, the zone where there's a transition between central and peripheral myelinization. That's where a lot of people think schwannomas are more likely to occur with cranial nerve schwannomas, but cranial nerve 2 never has that transition because it's all central. And the myelinization is all glial based rather than Schwann cells. Good question. Okay, next.
All right, so Jyotsna, are you on the call?
Yes, can you hear me?
Yes, ma'am.
Okay. So this case, we have first top left, we have a CT, non-contrast CT. The basilar is enhancing, so post-contrast CT. And the bone window of the same. And on the bottom left, we have a T2 axial MRI and diffusion MRI. So we have a CSF, so going to the top left, we have a CSF attenuating lesion in the left middle cranial fossa, and it is actually causing mild expansion of the bone, mild expansion in the region with some osseous, just osseous expansion. And on the T2, we have CSF density, and it just has like mass effect on the adjacent temporal lobe, but nothing else, no edema, nothing else. And on the diffusion, well, if it is, I was going to say arachnoid cyst, but then I see on the diffusion, it's not bright. There's
Let's say that's artifact.
That's a diffusion artifact.
Yeah, let's just say that's artifact. That part is not real. So focus on this part, right?
So with an arachnoid cyst, I wanted to see it to be like a T2 shine through, so it should be bright on diffusion.
Well, what do arachnoid cysts follow the signal intensity of?
CSF. Oh, so yeah, it's an arachnoid cyst.
Is this a good location for an arachnoid cyst?
Yes, most of them are seen in the middle cranial fossa.
This is the best location for an arachnoid cyst. That's right. So the anterior aspect of the middle cranial fossa is the most popular location for an arachnoid cyst. That's exactly right. And because it's not bright on the diffusion, you can differentiate this from what?
Epidermoid.
Epidermoid cyst. Exactly. Great job. Okay, next case.
So in this, we have top left, we have a T1 without contrast of the skull base, like at the level of the parotids actually of the neck. And then we have a T1 post contrast on the right. And then these are like on the bottom left, we have it's a T2 sequence, but it is like a flare kind of sequence with fluid,
something like that, yeah.
Fat suppressed sequence. And then this is also a T2 fat suppressed sequence.
That's right.
Okay, so on the T1, it looks like hypointense, and it's located within the parotid lobe, within the parotid gland, and it's T2 bright. So it's fluid containing, and then it's not suppressing with fat suppressed. So it could be like a parotid cyst. It could be necrosis within a parotid lymph node.
Well, what did you say this sequence is?
T2.
What if this is a T1 post? Maybe these
sorry,
guys are
that was the
T2.
T1 post.
What if
So
this
my
one is a
bad.
T1 post?
Yeah, that was the T1 post. So that could be, so it's actually for pleomorphic adenoma, it can enhance. T1,
Do they usually homogeneously enhance when they're small?
Yes. Yeah.
So
it
are
would
the surrounding soft tissues angry about this thing?
No, they seem to be just
Nobody
adjusting.
seems to care, right? What is this guy right here?
So that is the retromandibular vein.
Well, no, this is the retromandibular vein. It's the big vein that's in. This is the retromandibular vein. This is a muscle right there. What is that muscle?
Medial pterygoid.
I would say.
Well, that's the medial pterygoid. At the level of the mandible, the masseter is out laterally and the medial pterygoid is mandible. But there's a muscle right here that goes in between this space and this space. And it's not the anterior belly of the digastric.
So it is the posterior belly of the digastric.
The posterior belly digastric. That's right. What is the significance here of the posterior belly of the digastric for us with masses of the suprahyoid neck? It separates this space from this space. What are those two spaces?
Carotid space.
The parotid and the carotid space. That's right. So the carotid space and the parotid space are separated by the posterior belly digastric. So if we have a mass at that location, we often find that posterior belly and see which way it's pushed to help us guess where that mass is coming from. Exactly. So this is a great case of a benign mixed tumor. If you thought this was a minor salivary gland carcinoma, where might you look for tumor spread around that area?
Perineural tumor spread.
And where would you be looking for perineal tumor spread?
Along the facial nerve.
Along the facial nerve, that's right. Yeah. So you're going to look where? Where does the facial nerve come out of the skull?
It runs along with the retromandibular vein.
It goes just lateral to it. We think about it going just lateral. So we think about the retromandibular vein dividing the parotid into a superficial and a deep lobe, roughly at that location. We actually connect the retromandibular vein to the stylomastoid foramen. So that's your superficial and your deep lobe. The parotid doesn't actually have a superficial and a deep lobe. It's just that it goes through it and divides it. But where does the facial nerve come out of the skull base? Stylomastoid foramen. So you find little 7 right there and right there. And you want to see a good fat pad on the T1 pre around there to look for perineural tumor spread on facial. That's right. Okay, good job. Great appearance for a benign mixed tumor or pleomorphic adenoma. Is that important to mention before they do surgery?
Yes.
Why?
Because they don't want to cut the facial nerve.
They don't want to cut the facial nerve. What about these tumors as a pathology entity? Some tumors are very important in terms of their workup because they spread, like in lymph nodes, or they might get nodes in the belly or something else in a different area. Is there anything interesting about benign mixed tumors or pleomorphic adenomas in terms of either distal spread or local regional recurrence?
So even though it's a benign tumor, it's known to have a regional recurrence. So even though you do like a superficial parotidectomy, sometimes they can have a regional recurrence.
Yeah, the trick is you don't want to do an excisional biopsy. If you cut into this thing, you seed the surgical bed, and this guy will come back 15 years later with 15 small BMTs. So you want to cut out the entire lesion in toto, kind of, and deliver it all into the wound. That's right. Okay. Let's see, we did that one. Going backwards. Next case.
Okay, so we have 2 studies from 2017 and 18. Both are post-contrast T1 MRIs. Yep. And this is at the level of cavernous sinuses. So we do see the ICA, we do see the cavernous sinus enhancing.
Any clinical history you want to know?
Yeah, sure. Yes.
So might you want to know what was going on back here? He was having a lot of pain. It really hurt. And they gave him steroids. And then when he came back in 2018, he didn't have that pain anymore.
Okay, so there seems to be like some fullness in the region. Okay, so this is probably what was mentioned earlier, like a idiopathic inflammatory syndrome extending into the cavernous sinus. Like it's bilateral, so probably not Tolosa Hunt, but yeah, IOID, and then he responded to steroids.
IOID, that's exactly right. Or Tolosa Hunt, if you like to name stuff after dead people. You have that low-grade idiopathic inflammatory process that's in the cavernous sinuses. And this is just a nice case we had where they actually treated the guy, and over time he got better, so that enhancement went away. Not something you often see. That's right. So this was a bilateral kind of Tolosa Hunt or pseudotumor that was very painful back then. Great. Okay, next.
Thank you. I'm sorry, that was me. Okay.
Was that your third case, or do you want one more?
No, sure, I can go ahead.
Okay.
So, yes. So first we have CT axial bone window, and then on the right we have CT post contrast at the base of basically at the middle cranial fossa region. So we have a large expansile lesion which seems hyperdense with like a calcified rim on the bone window, and then of course calcified rim and central enhancement within the on the basic CT soft tissue window. So this seems to be like a large aneurysm. It can be from the ICA, and then it has a lot of intraluminal thrombus within it, and the central part is like the actual remaining lumen.
Can aneurysms get this big?
Yeah, I guess it can. Yeah.
Yeah, there's a whole thing called giant aneurysms. That's right, where they can be huge, over 5 centimeters. So you may not think it just by looking at something like size, but that is actually the lumen of the ICA, and this was all thrombus and clot, kind of in the wall with calcification. So when I first got this study, I said, well, it looks kind of like an aneurysm, but I've never seen an aneurysm this big. That can't possibly be an aneurysm. But it turned out that was. This guy had just had an aneurysm for decades, and this thing was just getting bigger and bigger and bigger without popping, apparently. So that was actually all thrombus in that area. Very good. Good job. Tell Bob Quincer I said hi.
Yeah, he's at UM, but I'll try.
Okay, thanks.
Yeah.
Okay, let's see, who's next?
All right, so next up we'll have Joe Wilson from UIC. He's in R3.
Okay. Joe?
All right, so we have 2 images here. On the left, looks like an axial non-con T1, and then we also have a DSA on the right. On the right, looks like we have some T1 hyperintensity peripherally with the right ICA. And then trying to look on the DSA. So I would be thinking about whether this person could have a dissection here. Or
they thought it was a dissection. He actually had this weird, he was at a chiropractor. He suddenly had this weird weakness on the other side afterward. But we did the MR and this was all bright.
Yeah.
Could that be bright if it just happened?
Yeah. And then I see some irregularity now that I'm looking again at the DSA, look a little.
Yeah, that whole blood vessel looks really weird going up there, right? Up here, it looks normal again, way up high at the top, but it looks normal down there. If this just happened, why is it bright on the T1? If you've blood in the brain like isolation, that's not supposed to be bright until 3 days. So what is going on here?
Is this hyperacute?
But if this is a T1 with fat saturation, why is that bright if it just happened? Because blood in isolation in the brain isn't supposed to be bright until 3 days. Have you ever heard those rules about blood in the brain? Like Indian babies have itty bitty baby doo-doos or something?
Yes,
the chart that goes around.
Yeah, the changes in your T1 and T2.
How blood evolves over time, right? T1 and T2. So if something's bright on T1 and it's blood in isolation in the brain, it shouldn't be bright until it's 3 days old. But in other parts of the body, those rules don't apply.
Because there's no blood-brain barrier here.
We don't have the blood-brain barrier here, and blood is going to evolve differently. So if we have blood mixing with CSF, and this is a tearing, a delamination, where we're tearing the intima away from the lamina, and the blood is delaminating away along its blood vessel. So it doesn't follow those normal rules. So if somebody goes to a chiropractor and they suddenly get weakness on one side, we do the axial T1 with fat set, just like this, to look for that bright signal. Even if it just happened, it'll be bright like this, because that blood is different than the rules are that we talk about in the brain. So that's a good case for a dissection there of the carotid. That's right. Okay, next case.
All right, so we have on the left an axial contrast enhanced CT of the neck, and then on the right, coronal. See kind of an ovoid, peripherally enhancing. Oh wait, that looks like it might be jugular to me on the right, because I see on the left I see normal carotid, and then I see enhancement in the left jugular.
So what's this guy?
That would be sternocleidomastoid.
SCM, what's that?
Jugular.
What's that?
Internal carotid.
Common, what's that?
Sorry. Thyroid.
Thyroid. Okay, so the other side, what's that?
Thyroid.
What's that?
Common carotid.
What's that?
That would be jugular.
And what's that?
And then that would be SCM there. And then.
Okay. So the jug is, it's a tube kind of going up and down.
Yeah, it looks like it's thrombosed to me. And then I see a good amount of surrounding fatty sort of inflammation. So
right, dirty fat, stranding in the fat, creeping fat, something.
Yeah, so could this be like a thrombophlebitis here?
Thrombophlebitis, that's right. So it's more than just thrombosis. If the guy had a CVO, like somebody had put in an internal jugular vein, and they just took it out, you know, because that guy would clot it off his jug or something like that. So you have changes around it. So it's more than just thrombosis. This is internal jugular vein thrombophlebitis. We have a lot of infectious inflammatory changes that are kind of around it. That's right. Good job. Okay. So, you know, did he have a CVL? Why does he have this? Every now and then there are rare cases where you can get tumor that's actually in the vein and extending along it. Good. Next case.
All right. So here we have on the left axial, on the right coronal. CTs through the orbits. Look like we have symmetric bilateral extraocular muscle enlargement. So based on the pattern.
What do you think about the position of his eyeballs?
We've also got a good amount of proptosis bilaterally.
Proptosis, his eyeballs are trying to escape his skull. So we have two big questions we want to ask, and those are?
The acuity and whether or not there's any associated pain.
Did the proptosis happen fast or slow, and does it hurt? Let's say it happened very slowly. Like you told this guy he had proptosis and his eyeballs were way out here, and he didn't believe you. You had to tell the guy, take out your driver's license from 4 years ago. Even though his family was there before him, they didn't think he had proptosis either. He said it doesn't hurt, and apparently it's happened very slowly over time.
So my lead suspicion would be like thyroid eye disease.
Thyroid ophthalmopathy, or yes. Thyroid eye disease, or Graves' disease, if you like to name stuff after dead people. So we have enlargement of the muscles there. What is the normal enlargement that the order of enlargement of the muscles that we often talk about?
So the mnemonic would be I'm slow. So inferior, right. Medial, superior, lateral, and then your superior oblique.
Oblique, oblique, right. And sometimes it's just prominent fat. Sometimes there's just a lot of fat back there. And sometimes we see low density in the muscles, especially on MR. We sometimes you hear people talk about glycogen deposition or something that's happening in those rectus muscles themselves. But I'm slow is what we often talk about with thyroid ophthalmopathy or thyroid eye disease. Right. Good. Okay. Next case.
All right. I think that was his third case. And I think that we have gotten through everybody.
Great. Good job, guys.
Yeah, awesome. Well, so we are going to close out. Just wanted to give Dr. Wiggins a shout out for giving us his second head and neck board review. Thanks to all the residents who joined today, and thank you for volunteering for taking cases. Thank you. We hope everybody found this useful. If you guys look in the chat window, April just posted a survey. I'm sure you guys remember this from last time. Just go ahead and take that survey. It's just very short. Use that for any future ideas for future board review sessions. And if you know a faculty who would potentially want to give us a board review, go ahead and put that in there and we can coordinate trying to get them to do this for us. Also, if you have any feedback, suggestions for Rad Discord, go ahead. You can message any of the moderators or myself, and then we can definitely talk about it. Good luck studying and have a great rest of your day.
Thanks, Dr. Wiggins.
All right, thanks, guys.
Thanks, Dr. Wiggins. Bye.
Thank you so
Have
much.
a good day.
Thank you.